Hello everyone, my name is Dr. Amelya and I'm a prosthodontist. First of all, I would like to say thank you for watching my video. And in this video, I would like to share to you some of the information about how to decide the correct implant positions, angulations, and depth. So in this presentations, there will be three main topics that we're going to discuss. First is about implant positions, implant angulations, and the depth of implant placement. Before we go further into details, I would like to briefly explain to you about prosthodontic classifications for implant prosthesis. According to MIS, there are 5 types of implant prosthesis. 3 types is for fixed prosthesis and 2 is for removable prosthesis. For the FP1, it is a fixed prosthesis that replaces only the clinical crowns and looks like a natural tooth. But for the FP2, it replaces the crown and also a portion of the root. So usually the crown contour appears normal in the occlusal half, but it is elongated and hypercontoured in the gingival half. And for the FP3, it replaces the missing crown and also the gingival color and a portion of the dentulocyte. For the RP4, it is a removable prosthesis. It is overdentures that is completely implant supported. Meanwhile, for the RP5, it is overdenture supported both by soft tissues as primary and also implant as secondary. There is a relationship between crown height and implant length. So as the crown height increases, available bone height decreases, which means there is only shorter implants. So now let's go further into details about implant positions. In the fixed implant prosthesis, we have what we call key implant positions, and there are 5 rules regarding this matter. The first rule is to minimize cantilever, and the second rule is to limit the number of adjacent pontics to less than 3 pontics and also use of intermediary abutment. For the third rule, the canine is important key implant positions, and it is recommended to do a canine implant whenever this side is available. For the rule number 4, the first molar is also a key implant position. So when the first molar is required in an implant prosthesis, the implant located in the first molar is always recommended. For the rule number 5, if we divided the arch into 5 segments, we have to have at least 1 implant in each segment. And for the correct implant positions in the maxillary anterior, in the mesiodistal locations, it is usually located in the middle mesiodistal of the final restorations. And between natural teeth and implant, there should be at least 1.5 mm of bone remaining. This to minimize the alveolar bone resorptions on the adjacent side. Depending on the incisive foramen positions, a central incisors implant may need to be positioned 0.5 to 1 mm distal from teeth axis and may also require a smaller diameter implant than usual. For the labiopalatal positions, place the implant lingually, and ideally after implant placement, the crestal bone should be at least 2 mm wide on the facial aspect of the implant and 1 mm or more on the palatal aspect. Because if the bone loss occurs in the implant, the facial plate will remain intact and not causing recessions on the facial of the implant crown. And we can also use the imaginary line that connects the incisal line of 2 adjacent teeth, and it should match the labial side of the implant. And for the correct implant positions for mandibular anterior, the mesiodistal locations, we have to put the implant in the center of the final restorations and maintain proper distance between natural teeth and implant at least 1.5 millimeters. And for the labiolingual locations, we have to place 0.5 millimeters to the lingual side compared to the tooth axis to consider it for aesthetics and prevent labial bone perforations. For the correct implant positions for the posterior teeth, in the mesiodistal locations, we have to place the implant in the center mesiodistal width of the crown, and between implant to natural teeth ideally should remain 1.5 to 2 millimeters from the interproximal cemento-enamel junctions and root. If less than 1.5 millimeters, it may cause periodontal complications, adjacent tooth damage, bone loss, or a non-ideal emergence profile of the final crown. If more than 2 millimeters, there can be a cantilever effect on the marginal ridge of the implant crown, which may lead to biomechanical overload or aesthetic issues. And in immediate implant placement, we should place the implant in the middle of septal bone for initial fixations. And for the mesiodistal positions, between implant, it should remain 3 millimeters or more of space. It allows adequate room for the interdental papilla and tissue health and minimizing horizontal bone loss. It allows the patients to cleanse the embouchure, allows adequate space for transfer cupping during prosthetic impressions. The width of the crestal defect is usually less than 1.5 millimeter. So if there is a 3 millimeter space, it will not convert an angular defect next to the implant to be a horizontal defect that may increase sulcus depth and also cause loss of the papilla height and increase the food impactions. These are an example of pictures when there is not enough space between implant, which result in bone loss. For the buccolingual positions, the implant should be positioned in the center of the alveolar ridge with minimum remaining bone 1 millimeter each on buccal and lingual aspect. For the premolar implant replacement, the implant is placed slightly buccal under the buccal cup tip, 1/3 buccal and 2/3 lingual. This improves the cervical emergence profile, ensure a proper aesthetic result, and avoid ridge lap crown. And for the first premolar implant, it may need to be placed parallel to the canine root and may require a shoulder implant. So we should evaluate the canine angulations and vertical height limitations. In the second premolar implant, a shorter implant than ideal is a common consequences, because the root apices may be located over the mandibular neurovascular canal or foramen or maxillary sinus, and the foramen is often 2 millimeters or more above the neurovascular canal. For the first molar implant replacement, the molar implant diameter should be larger than a premolar implant. When the mesiodistal is 7 to 8 millimeters, it is suggested to use a 4 millimeter implant body. And when the mesiodistal is 8 to 12 millimeters with buccolingual width more than 7 millimeters, it is suggested to use a 5 or 6 millimeter diameter implant body. If we use a 4 millimeter diameter implant to support 12 to 14 millimeter mesiodistal crown, it can cause an overload and it will create a 4 to 5 millimeter cantilever on the marginal ridge of the crown, where the magnified occlusal forces can cause bone loss, increase abutment screw loosening, and increase abutment or implant failure. This picture shows a cantilever effect causing a bone loss followed by implant fractures. When the mesiodistal space is 12 to 14 millimeters, we should gain additional space and make it to be 14 millimeters so that we can use 2 4 mm diameter implant. When the mesiodistal is 14 to 20 mm, whenever possible, we should use 2 implants to replace the largest single molar space to reduce the cantilever loads and also reduce the abutment screw loosening. We should use a wide diameter implant in a poor quality bone or for immediate replacement of a failed implant. And for implant positions with respect to the vital structures, the implant should be placed more than 2 mm from the inferior alveolar canal or mental foramen. If it is less than 2 mm, it can increase the risk of compressions or traumatic injuries to the nerve trunk. An implant should be positioned just short of the nasal floor without engaging the thin inferior floor of the nasal cavity. As for distance from the inferior border of the mandible, we should evaluate the angulations of the anterior mandible with a 3D imaging to minimize the possibility of perforating the lingual cortex, because if inferior border of the mandible is perforated, bleeding may become evident. And for the distance from the maxillary sinus, there are 4 treatment options according to the quantity of bone from the crest of the ridge to the inferior border of the sinus. SA1, if there is more than 12 mm of bone, so implant replacement that does not penetrate the maxillary sinus. SA2, if there is 10 to 12 mm of bone, and implant placement with the penetrations into the sinus approximately 1 to 2 mm without bone grafting. And for SA3, there are 5 to 10 mm of bone is present and implant placement along with the grafting, either with the crestal or lateral approach. And for SA4, there are less than 5 mm of bone and we need a sinus augmentations from a lateral approach with delayed implant placement. Next, let's talk about implant angulations. For the correct implant directions for the maxillary anterior, in the mesiodistal directions, we have to consider the natural tooth axis of the anterior teeth. Generally, maxillary anterior teeth roots have a slightly distal curvature. And in buccal lingual directions, we should place the implant parallel to the tooth axis. For the correct implant angulation in maxillary anterior, there are 3 labiopalatal angulations of the implant body that are suggested. First is under the incisal edge of the final restorations. Second is similar to the facial positions of the adjacent natural teeth. Third is within the cingulum positions of the implant crown. For the facial implant body angulations, the maxillary anterior teeth have incisal edge 12 to 15 degree more palatal than the facial emergence positions of the crown. So when implant is angled to the facial, an angled abutment of 15 degree must be used to position the incisal edge more palatal. This 15 degree off axial loads increases the force to the abutment screw implant bone complex by 25.9%. This will increase risk of abutment screw loosening, crestal bone loss, and cervical soft tissue marginal shrinkage. This picture shows example of implant that is placed to facial. For cingulum implant body angulations, the implant is angled more palatally with an emergence under the cingulum of the crown, and usually this is used when implant insertion is in a width deficient ridge because of the facial bone loss, or when a screw retained crown is used in the final restorations, or to increase the bone thickness on the facial of the implant body. In these angulations, they may need a modified ridge lap crown which extends 2 to 4 mm to the facial. In this type of crown, it will be more difficult for plate control, especially in the gingival sulcus under the ridge lap crown. The center of the implant is located directly under the incisal edge of the crown, so in this case we can use a straight abutment for a cement retained crown. It can accommodate some facial bone loss that often occurs before the implant placement. And there will be less force to the implant because force comes through the long axis, which decreases crestal stresses to the bone and abutment screws. It may also be used for screw retain restorations with angled abutment, and the coping screws for the crown may be located within the cingulum. In these angulations, it does not require a facial ridge lap of the final crown, so it will not compromise the oral hygiene, but there is still risk of screw loosening. For the correct implant angulations in the mandibular anterior, we should place implant in the center of the mesiodistal tooth space, and generally, mandibular anterior teeth roots have a straight vertical directions and in buccal-lingual directions. Ideally, the implant is in the center of the ridge with minimum 1 mm of bone remaining on the buccal and lingual side. And we should place the implant more lingually, parallel to the tooth axis. And this picture shows the angulations for the cement retain, which is through incisal edge, and this one is for screw retain. The angulations for the screw is through the cingulum. For the correct implant angulations for posterior teeth, in the mesiodistal directions, the axis of natural teeth normally have a mesial tilting, so we have to match the implant directions with the teeth axis. And in general, the posterior teeth roots are curved distally, so need more considerations for implant directions for these teeth. And for the buccal-lingual directions, the implant replacing the maxillary molar will incline to buccal, whereas mandibular molar will incline to the lingual. For the correct implant angulation with respect to the prosthesis type, for FP1 and FP2 prosthesis in labiopalatal positions, for a cement retained anterior, the ideal angulation is slightly lingual to the incisal edge. In this case, a straight abutment may be used, which is aesthetically more pleasing and prosthetically less complex, and resulting forces are concentrated along the long axis of the implant, minimizing damaging shear forces. For a screw retained anterior, the implant should emerge within the cingulum area of the anterior tooth, so the axis hole does not affect the aesthetic of the restorations. For posterior region, either cement retained or screw retained, the long axis of the implant should emerge within the proximate center or at the central fossa of the prosthesis. Next, let's talk about implant depth. So what is the correct implant depth? The implant platform should be placed approximately 2 to 4 mm apical to the adjacent cement enamel junctions or free gingival margin. Ideally, implant is placed 3 mm from the CEJ or FGM because of the biologic width, emergent profile, and aesthetic reasons. This picture shows an implant that is positioned too apically and implant positions too coronal. For implant placed more than 4 mm below the adjacent CJ or FGM, which means it is too deep, it can cause an unfavorable crown height space or crown implant ratios. and it can also cause periodontal complications because of the inability to perform proper hygiene and also causing bone loss on the adjacent teeth. And there can cause a black triangular in the interproximal regions because of the absence of interdental papillae and also with the greater sulcular probing depth. And prosthetic are more complicated with difficulty in impression taking when placing abutment and also when seating the prosthesis. And with deeply placed implant, often the facial plate will result, especially if the facial inclination is present. And long-term sulcular health is decreased because there is a minimal to no cortical bone present, and the trabecular bone around the crest module is weaker against occlusal load. Because of increased crown height, it will increase moment force, and in turn it will increase risk of bone loss in the weaker trabecular bone, which may also result in soft tissue shrinkage over the long-term period. The increased crown height also increases force to the abutment screw and increases the risk of screw loosening. For the implant placed at 3 mm below the adjacent CEJ of the FGM, this condition is the ideal depth because it is similar to the most desirable bone level before tooth loss, and these positions provide 3 mm of soft tissue for the emergence of the implant crowns on the mid-facial regions and more in this interproximal region. This also increases the facial soft tissue thickness, which can mask the darker color of the titanium implant body. And it should be noted that the FGM of the lateral incisors may be 1 mm more incisal than the adjacent central and the canine natural tooth. If the implant plays less than 3 mm below the adjacent CEJ or adjacent FGM, which means this will be too shallow, there will be inadequate emergence profile, which is a transition from the narrow diameters of the implant compared with the wider diameters of the crown. And it will also cause decreased retentions of the implant, which may lead to uncementable restorations or component fractures. The porcelain crown may not be subgenival enough to mask the titanium color of the abutment or implant below the crown margin. It can also cause a poor resultant aesthetic because the implant abutment or implant body will show through, resulting in cervical darkness. In these pictures, it shows implant that is inserted too shallow, so you can see there is a black shadows in the cervical area of the implant tooth. Because the implant position is too shallow, there will be an abrupt changes from the prosthetic platforms to the diameter of the restorations, which will result in hygiene difficulty. There is a simple guide for the implant depth control. And in this case, we use the submerged type implant. So we measured the sum of the soft and hard tissue above the implant, and it needs to be over 3 mm. So in the clinical situations, it usually more or less 1 mm is recommended. It is recommended to place the implant 1 mm deeper than the alveolar bone crest. Healing abutment can be used as the guide for the implant depth control. So we choose the 5 mm diameter with the 5 mm height healing abutment. Then we evaluate the exposed healing abutment above the soft tissues. And in thin gingival cases, there is not enough soft tissue to create sufficient biologic width. So implant needs to be placed deeper to cause the bone resorptions that will convert to soft tissues and form biologic width. And we also have to know the interocclusal space that we need in respect to the prosthesis type that we're going to use. For the FP1 fixed implant prosthesis, ideally you should have crown height space range between 8 to 12 mm. For a cementable prosthesis, ideally minimum 8 mm of space for a crown height space is required. And this consists of 2 mm of occlusal materials. It also depends on what materials that you use, and minimum 4 mm abutment height for tensions, and 2 mm above the bone for biologic width dimensions, but this one is not include sulcus because the crown margin may also be 1 mm subgingival. And if there is not enough space, then we use a screw-retained prosthesis or change to the FPD treatment plan. And for removable prosthesis, it is oftenly require more than 12 mm of crown height space. And crown height space is defined as excessive when it is greater than 15 mm. So the minimum interocclusal space for the cement retained prosthesis, if you use zirconia, may be 7 to 8 mm. For the PFM, it can be 8 to 10 mm. And for the screw retained prosthesis, it is 5 to 6 mm for zirconia or PFM. And for the submerged type or non-submerged type, in general, the cement retained prosthesis need minimum 8 to 9 mm of occlusal space because it requires 4 mm minimum for the abutment height and a minimum 1.5 to 2 mm for occlusal surface prosthesis. And for the gingival color, it must also not invade the biological width. And in cases with smaller interocclusal space, you should use a screw-retained type prosthesis. In the next slide, I would like to introduce to you some of the tools that can also help you to get the correct implant position. This is an example of positioning guide kit. So the advantage of using the guide kit is to get the accurate implant placement positions. It is more convenient and precise positions because the use of single guide and also guide pin, and you can also evaluate the width of the crown by using the plastic sleeve. And you can also get accurate implant placement directions by using the guide pin. In the positioning guide kit, there are 3 guides that you can select. For a single and bridge case, you can use the single guide. For the bridge case, you can also use the fan type. And for the full mouth case, you can also use the denture guide. For the fan type guide, there will be 4 holes in each guide, and each hole have different measurement from the implant position. So let me summarize my presentations for today. First, we have to maintain proper distance between natural teeth and implant, at least 1.5 mm. And ideally, there should exist 3 mm or more of space between any 2 adjacent implants. And if excessive mesiodistal space more than 4 mm exists between the implant body and the adjacent tooth, a biomechanical disadvantage will result because of the cantilever effect. For implant placement in anterior maxilla, ideally the crestal bone should be at least 2 mm wide on the facial aspect and 1 mm or more on the palatal aspect. The implant platforms ideally should be placed 3 mm apical to the adjacent cement enamel junctions or free gingival margin. A fixed implant prosthesis for cement retained prosthesis usually should have crown height space range between 8 to 12 mm. In cases with smaller interocclusal space, less than 8 mm, you should use a screw-retained type prosthesis. So thank you for watching my video, and if you need more information or you have any more questions, please feel free to contact me on my email address. So thank you very much and see you on the next video.